Hi there, and welcome to Anti-Nuclear Antibodies, the Significance and Limitations. I'm Dr. Alex, and this is the Naturopathic Clinical Laboratory Diagnosis 1 Introduction to ANAs and the Laboratory Testing of Rheumatologic Diseases. So what are we going to cover? Well, we're briefly going to cover, and I do mean just very rudimentary is our coverage of this at this point. What are ANAs, acute phase proteins, and rheumatoid factor? How useful are these and how not useful they can be? So starting with this slide, you can see the question asks, what are antinuclear antibodies? And then the answer, before we even look at any more of the text, we see that antinuclear antibody patterns are represented in different ways on this slide. So we have on the right side there, we have the martini glass that has a cartoon representation to help you remember the peripheral, the speckled, the nucleolar, and so forth. And then on the left, we have another more realistic cartoon drawing that does the same thing. And then we have the actual immunofluorescence at the bottom, left and right, where I think we have the rim there, peripheral rim there on the left, and we have, looks like speckled on the right. And we could look here and see that the peripheral rim is associated with systemic lupus, and we can see that the speckled is associated also with lupus, Sjogren's, and some other conditions. So what are antinuclear antibodies? Well, they're antibodies to nuclear proteins. And what are nuclear proteins? Those are proteins that have been synthesized in the nucleus and distributed to their respective sites in the cell. Okay, and I guess this is a representation of that. You can see some names that will begin to make sense later in your study of the laboratory testing of rheumatologic conditions. I just want to introduce them to your eyes now. All right, and we can see here the nucleolar and the rim and the speckled. And the homogeneous patterns. And then this is an actual photograph of the representative antinuclear antibody indirect immunofluorescence staining patterns. And then we can look through and see the homogeneous is A and B, and the nucleolar is C. You can see the nucleus there. And let's see, D is speckled, and E and F are the rim-like, and then G is the centromere, and so on. The importance of ANAs, well, clinicians can't really rely heavily on blood tests when it comes to rheumatologic conditions, except for certain tests that are highly specific, such as the case of systemic lupus. Improper application of ANA tests actually leads to misdiagnosis and inappropriate therapy and unnecessary healthcare expenses. Pretest probability is really useful when you're deciding to run ANAs to test for whether a patient has the laboratory hallmarks anyway of rheumatologic conditions. So a positive test result with high pretest probability helps make the diagnosis, but a negative test can help rule out the diagnosis. So again, what are ANAs? Well, they're the serologic hallmarks of patients with systemic ANA diseases or autoimmune diseases. And so here's an example of some of those sensitivity and specificity numbers. So you can see here the sensitivity and specificity of antinuclear antibodies in various connective tissue diseases. And there they are, with lupus being the highest, with 93 to 95% sensitivity. Here's another slide that demonstrates those different patterns, homogeneous and diffuse, peripheral rim speckled, nucleolar, and centromere. And that would be the laboratory evaluation of rheumatic diseases, identifying antinuclear antibodies, and so forth. And so we can see there's the nucleolar cartoon, and there's the peripheral rim, the speckled, and the homogeneous. Okay, and you can see which disease is associated with which antigen. So ANAs can provide further diagnostic and prognostic data concerning patients who have minimal symptoms or who have clinical features of more than one autoimmune disease, such as a young female with polyarthralgias, fatigue, malar rash, and a positive ANA. Looks like lupus from here. Acute phase reactants. Acute phase reactants now are proteins whose plasma concentration increases positive acute phase proteins or decreases, that would be negative acute phase proteins, by at least 25% during inflammatory states. So it makes sense that we would test acute phase reactants to see a person's level of inflammation. The effect of inflammatory molecules such as interleukin, so that's IL-6, IL-1, tumor necrosis factor, interferon gamma, transforming growth factor, causes a change in the hepatic protein synthesis collectively known as the acute phase response. So erythrocyte sedimentation rate, ESR, and CRP are the most widely measured acute phase reactants in clinical practice. And the ESR, as we've talked about in class, is just a measure of the height of the red blood cells, the measure that the height of red blood cells that's going to fall through plasma in a specific tube over a period of 1 hour. So the measure of the height of erythrocytes. I don't think I said that right the first 2 times. ESR can be greatly influenced by the shape and number of red blood cells as well as other plasma constituents. So fibrinogen, globulins, and albumins can all affect the ESR. It can be spuriously high in the absence of inflammation, as in anemia, nephritic syndrome, and hypergammaglobulinemia, and it can be spuriously normal in cryoglobulinemia and hemoglobinopathy. So hopefully you understand what that means. ESR increases steadily with age, and the upper limit varies with sex, hence ESR is difficult to interpret as compared to the CRP. I don't actually use ESR. Unless, as I said in class, it's a cost issue. I need a really quick screen for inflammation. There you go. The concentration of CRP in serum is more sensitive than the ESR to evaluate and monitor inflammation, and it's independent of those factors that affect the ESR. It also correlates better with disease activity, and the rise in the CRP level is seen much earlier than that of other acute phase proteins, acute phase reactants, usually 4 to 6 hours after tissue injury. So what about the rheumatoid factor? We've talked about ANAs, we've talked about acute phase proteins, at least the ESR and the CRP, so now let's look at rheumatoid factor. Well, rheumatoid factor is detected in a wide variety of rheumatic as well as non-rheumatic conditions, so it's commonly used in diagnosing rheumatoid arthritis. The sensitivity for this rheumatoid factor in diagnosing rheumatoid arthritis is about 50%, all the way up to 80%, and the specificity is 85 to 90 as reported by some studies. In patients with advanced disease. Rheumatoid factor may be negative in the early stages, however, but the positivity increases over time. So we don't use rheumatoid factor alone to diagnose rheumatoid arthritis because 15 to 20% of patients with rheumatoid arthritis never have RF positivity. They're seronegative, and 2 to 10% of healthy people have RF positive on a laboratory value. That doesn't mean they have rheumatoid arthritis. So a positive RF alone does not confirm RA, and a negative one doesn't exclude it. So the best time to obtain the test may be when the suspicion of rheumatoid arthritis is low, and in that case, a negative test is going to provide significant reassurance that the patient doesn't actually have it. So rheumatoid factor positivity in different disease phases. So you can see the rheumatic conditions. So you can see polymyositis, dermatomyositis, fairly low. Sjogren's is fairly high. Rheumatoid arthritis is fairly high. Cryoglobulinemia goes all the way up to 100%. The limitations in the utility, and I should say the limitations of the utility and reliability of ANAs and other labs in the diagnosis of systemic autoimmune. Well, number one, they can be found in association with a lot of autoimmune disorders. And those autoimmune disorders may not be identified or defined by the antibodies that you run. You can also have positive ANAs in certain infections and other disorders and in patients who are taking certain drugs. So the take-home message is that the presence of ANAs doesn't mandate the presence of illness. So they can be found, these ANAs and other tests can be found in otherwise normal individuals. False positive ANAs, i.e. ANAs in the absence of autoimmune disease or known antigenic stimuli, are more commonly seen in women and elderly patients. Okay, 3 is the accurate interpretation of the different nucleolar patterns is confounded by a couple of difficulties. So the upshot here is operator dependence. So the recognition of these patterns is really dependent on who's looking at them. As a result, A positive ANA, though it's useful and important, should be interpreted with caution and within the appropriate clinical setting. And further, a good history compounded with a thorough clinical examination remains the mainstay of your diagnosis. So the take-home message, start with a good history and physical exam. Then an ESR-CRP, those acute phase reactants, and a rheumatoid factor for screening, and that's really kind of a bad word here. Screening isn't exactly accurate. So you would run a rheumatoid factor if you suspect the conditions in which a rheumatoid factor might be positive and useful, like rheumatoid arthritis. And then move on to ANAs if the pretest value warrants it. Okay, so I might, in the presence of a strong history and my clinical suspicion is high, I might just go ahead, and I'm not thinking rheumatoid arthritis, I might just go ahead and run the the CRP and ANAs. Here's some examples of ANAs. And suspect ANA disease, obtain the ANAs, and then you can see what happens if it's negative versus what happens if it's a low titer versus what happens if it's positive. And this is an algorithm for the use of antinuclear antibodies in the diagnosis of connective tissue disorders. FANA there stands for fluorescent antinuclear antibody test.